There we go. Okay, so on Thursday we went through the normal cardiac arrest. There's a couple of things we just need to think about where we will try to change, where we need to change that a little bit, okay? So, if all else fails, you go back to the basics and you do exactly as you did for a normal cardiac arrest. Then, if someone is pregnant, so if a lady is pregnant and she is more than 20 weeks pregnant, i.e. you can see the bump, then remember that bump, just like we said, the tongue falls backwards into the mouth because all the muscles relax. So that baby and uterus and everything there, which will weigh a couple of kilos at that point, will also fall backwards. Now it won't fall backwards and block the airway, but will fall backwards and it will compress the inferior vena cava, so the main vein coming up from the legs and the abdomen to the heart, and will also compress the aorta. Now we're not so worried about it compressing the aorta because we don't want blood flowing into the legs, that's fine, but we are worried about it compressing the vena cava because that will stop blood flowing back from the legs to the heart. So in a lady who's pregnant, more than 20 weeks, i.e. you can see the bump, one person during the cardiac arrest will have to physically move the baby over to the left. So you have one person doing the airway, you have one person doing chest compressions, and then you have a third person holding onto the bump and literally pulling it over to one side. Does that make sense?
No.
You're looking.
No, it's a bit.
What?
It's a bit like you need to know how to do it, or just like literally.
Literally, yes. You put your hands on the tummy. You feel the lump, and you just pull it over to the left.
And basically, this is what it might cause damage, but we rather the mummy.
No, it won't. It doesn't cause any damage to the baby. Besides the point that the baby is already dead anyway, because the baby is the least important organ in the mother's circulation. So the first thing that goes when you have poor circulation is the baby.
Okay, so baby anyway.
Baby's anyway gone. Don't worry about the baby. What we're doing is we're trying to do our best for the mother, and we want to get that pressure off the vena cava to allow blood to flow back to the heart. So we need to pull it over to the left.
Is that always a definitive moment? Is that always a definitive moment? Mum has a cardiac arrest, baby's gone completely. That's it.
Essentially, yes. Okay. Yes, we in hospitals they talk about doing emergency cesarean sections. Essentially, the baby is dead. The only reason they do cesarean sections in the hospital is to take that pressure off the vena cava, not to save the baby. Sometimes babies will survive, and those of you who are learning chulin know all about calves which are born after the mother's been shechted, and that does happen even in humans. But in principle, we're treating the mother, not the baby. Okay. That all makes sense. So we're trying.
Yeah,
and
that makes sense. Yeah.
And then the other thing we need to think about, there's a significant percentage of the population that don't breathe through their nose and mouth. They have a stoma, so they've had an operation where they've had throat cancer, where they've had to have their throat, where they've had to have the voice box taken out, or they've had some sort of procedure even as a baby where the airways are very soft, so they've got a hole in their neck that they breathe through that, and that's called a stoma. So there's two types of these stomas. One is what we call a talking stoma, where they still have a connection from the lungs to the mouth, so they can talk. And then you can either ventilate them through the mouth or through the stoma. But you need to remember that whichever one you're not using, you need to block off so that the air doesn't come out of there, because the lungs will have more resistance than the upper airways. Yeah? Does that all make sense?
Yeah.
Or there are some people who have no connection between the mouth and the lungs, so they've had the larynx taken out for whatever, and it's been completely shut off, and they only breathe through the stoma, and then you need to remember to ventilate them through the stoma.
How would I know?
So you would know because you would see a hole in their neck, or you'd see a piece of plastic there.
How do I know if it's a connected one or not connected?
So you wouldn't know normally, But you use all your airway manoeuvres. So you do your head. So you look in the mouth. You clear out any obstructions. You've done your head tilt, chin lift. You put the bag valve mask over it. You see that, and you block off the stoma, and you try to ventilate, and you don't see the chest moving. So the next thing would be to go to the stoma and ventilate through the stoma. Okay.
If you ventilate through the stoma, how would you block the mouth?
So if you've tried before and it's not connected, then it's not a problem. If you haven't tried, so you just don't need to do the airway manoeuvres. Once the head goes back into the resting position, remember the tongue's going to flop back and it will block it.
Okay.
Yes.
No intervention. The tongue will block.
No, the tongue will fall backwards because there's no tone, so it will relax back into the back of the airway and will block it off. Okay. Now, remember that the hole here is not going to be the size of the person's face. So you adapt the mask to make sure that it's a smaller mask. And so if you're ventilating a stoma, so you can use an infant mask. Which have you seen the infant mask? The round plastic ones. So it's a much smaller mask, and basically you put a mask over the patient's neck, and it just covers the stoma. But you still use an adult bag, obviously. You don't take an infant bag and an infant mask. You take an adult mask and an adult bag and an infant mask, and all the airway equipment is interchangeable, so it doesn't matter. You just use an infant mask over the stoma to use that.
Alright, but what I see over here that so if available, use a catheter.
A catheter mount. So this is just a plastic tube, a flexible plastic tube that you can plug onto the stoma. No, you just plug it onto the stoma here,
Right.
and you plug the other end into the bag valve mask, and then you don't need to put a mask over
Would we
it
have
at all.
it in the
It's available. Yes, so it is available in the kit. Okay, it's just thinking about the different. This is thinking about the differences that we'll do in these situations. Okay. Any questions about any of that? Now, my next question is, when should we not be doing resuscitation? I know I brought it out there, but when should we not start resuscitating? So you're all going to be skilled at resuscitating people, and none of you are registered healthcare professionals, so you're not paramedics, nurses or doctors, so legally you're not allowed to declare someone is dead, and you're not dead until you're warm and legally declared dead. Very important for your pension. Yeah. So bearing that in mind, I'm going to resuscitate every single body that we come across.
If they have a DNR, they're not.
Okay, so if they have an advanced decision to refuse treatment, so they could refuse themselves. So sometimes patients come in and say, we've had a good life, we recognise that we're approaching the end of our life. This is more cancer patients who have a predictable end to their life, or much older patients, and they say, actually, when we die, we're happy to have reached that point in our life. We don't want to be resuscitated. So if they have an advanced decision, and that could be the patient, or it could be that they've had a discussion with their doctor, and their doctor has on balance decided that they are unlikely to recover from a cardiac arrest. If they were to recover from a cardiac arrest, they would not be at the level of health that they are currently, and their current level of health is not great. So therefore, there is no point in doing DNR, in doing CPR. So they will have a doctor's decision on their behalf saying that they won't have that treatment. Yeah.
When a senior clinician tells you that they're dead.
Yeah. So someone comes along and they've gone through the whole resuscitation and they've said that the person is not going to recover, and we do get to that point in resuscitations. Yeah. So someone who is allowed to declare the patient is dead has told you to stop. Yeah. Anything else?
Well, I have
There's a whole list there, isn't there? Yes, absolutely. So if you've arrived at something that is not compatible with life, you don't need to start resuscitating them. So if you've come across a car accident, car versus pedestrian, and you do your initial assessment, the patient isn't breathing, doesn't have a pulse, and then you notice that the back of their head is open, and there's no brain inside, there's no point in resuscitating them because the brain won't ever kick it back
It's a
in. Now I say what?
It's a non-brainer.
It's a no-brainer, absolutely. Yes. So absolutely, and that sometimes it will take you a little bit of time. So you might start resuscitating them, and then you find out that actually you've got a no-brainer, and then you can stop.
When I start,
Yeah.
am I allowed to stop?
We're talking about you are being allowed to stop. Yes. Okay. Or you don't need to even start. So if you notice it, there's no obligation to start even. Okay.
So there are cases where you can declare them dead.
You're not declaring them dead, you're just not starting CPR. So they're still not legally dead until a doctor or paramedic or nurse comes and says they're dead, but you have no legal obligation to start resuscitating them. Okay? So if they've been decapitated, so again, a no-brainer, but this is a bit of a larger no-brainer, where they don't have a head, then you don't need to start CPR. Or a similar massive injury. So if the body is split in half, yes, or a hemicorpectomy, yes, so the body has been cut in half, you don't need to start resuscitating. If you notice that the body has started decomposing, and that does occasionally happen where someone hasn't been seen for days and days and days, and then someone notices there's an awful smell coming from their flat, and they call the police, and the police come and they break down the door and they find that the person has been dead for a few
Or
days.
they call a drainage engineer. There is a small,
Yeah.
yeah, it's happened to us not once.
Do you know any good ones?
Huh?
Do you know any good ones?
No.
Yeah. So, and occasionally these things turn up in the news. A couple of years ago, there was someone who'd been dead for about 4 years in front of an air conditioning unit, so was mummified.
It was on ice.
He was on ice, mummified on ice, and they then found that, and they worked out how long he had been dead by the pile of posts in the front door. So you don't need to start resuscitating someone like that. Yes.
What about a case of catastrophic bleeding where there's such amount of blood on the floor that...
So it depends where that's come from.
Yeah.
If it's come from a massive injury that is not compatible with life, then you don't need to start resuscitating them. Yes. If there's a huge puddle of blood on the floor, but there isn't a major source of bleeding, so they don't have a massive injury that's caused it, you will still need to resuscitate them. Okay? And I've seen someone who's lost about 2 litres of blood, and they're still talking to you, but 2 litres of blood goes a very long way, and it covered the entire bathroom to a level of 3 millimetres. So we're talking about a massive amount of blood. So don't just use all the blood on the floor as a guide.
Yeah, if the pitches.
Yeah, if they don't have a pulse and you see lots of blood on the floor, you can't use that as a guide. But if you see that they don't have a pulse and they're missing 2 arms and 2 legs, and it's a fresh cut, then you can reasonably assume that they're not going to survive that. Okay.
It's a matter of common sense, basically. If you think the guy is literally dead.
No, it's not. It's not an issue of common sense. It's an issue of you've recognised that this body has no chance of recovery. It's not a common sense thing, because as I said, you could see a huge puddle of blood on the floor, but not see where it's come from, and no pulse, and you do need to resuscitate them.
Right. So if I'm coming to a place and I see someone, yeah, he's still alive, but let's say his brain is already.
They've got a massive head injury and half the brain is missing, and they're
he's
a couple of
still-
gasping breaths, then you probably don't need to resuscitate
Right.
them. Okay. Incineration, so if the body's burnt, it's a massively burnt body, and that does sometimes happen in fires where the body has been burnt to such an extent that there's no chance of recovery. Okay. There's something called hypostasis. So this is where a body has been lying in the bed for a couple of hours, and you see all the blood pooling. So it looks like they've got. So the top half of the body, and when I say half, I'm talking about gravity half. Top half of the body will be very, very pale, and the bottom half will have a very clear line where it almost looks like it's bruised because all the blood is just pooled there. Okay. So that tells you that the body hasn't had a circulation for a few hours. Okay. Or the last thing is if they've got rigor mortis. So rigor mortis is part of the process, is part of the dying process, where all the muscles lose all their energy and they become very, very stiff. So the body is almost like a board. And I remember going to a cardiac arrest here in Edgware, where the person died over the toilet several hours beforehand, and when we took them off the toilet, they still stayed in that shape.
That does go after a while as well, doesn't it?
It does go after, yes. So when the person dies, all their muscles are relaxed and they're very, very floppy and they flop all over the place. About 3 or 4 hours later, they develop rigor mortis, and that lasts for between a few hours and a couple of days. Usually about 5-6 hours, and then parts of the muscle break down. They lose that rigidity. At the same time, you'll start seeing the blood pooling at that point.
Not ever with somebody before they pass.
Yeah,
Straighten them out.
yeah. If you've been to a cardiac arrest and we've
They've been in recovery position otherwise.
no, we've managed a patient in cardiac arrest and we've decided for whatever reason that we're stopping. At that point, make sure that the patient is lying straight out. Otherwise, the Chevra Kadisha won't thank you. So if you leave them in a soft bed, they'll be bow-shaped, and then they'll have to fit into a bow-shaped cask. Okay. So yeah. So these are things. But if you've come to a patient and they are bow-shaped, then you know that they're in rigor mortis. So you don't need. At that point, you don't need to start resuscitating them. Okay. Okay. Now, AEDs. Did you touch on these?
Yes.
Yeah. Oh yeah, we
Touched
literally hands-on touched them.
You hands-on touch
Yeah.
them. So you know they're very, very simple. They're very, very basic, but they're very effective.
Yes.
You switch on here and follow the instructions. When are we going to use it? Any unresponsive patient who is not breathing normally. Okay. These machines are exceedingly safe. They will not shock a patient who may or may not have a pulse if the heart rhythm fits to a rhythm that should have a pulse. So if they have anything that the machine thinks might have a pulse, it won't shock.
Right.
Okay, so they're exceedingly safe. They don't shock automatically. So it's not that it's going to decide that the patient needs a shock and shock the patient. It will decide the patient needs a shock and it will tell you that the patient needs a shock. So you use it whenever the patient is unresponsive and not breathing normally, i.e. they're in cardiac arrest. When would we not use it? In a patient who's unresponsive and is not breathing normally. So absolutely you're right, we won't use it in a patient who's responsive because they don't need it, but when we've got a patient who's unresponsive and not breathing normally, when will we not use it?
In an environment where it's not conducive, it's a wet environment.
So an explosive environment or a wet environment, absolutely. What else?
They said wet was okay as long as the machine's not submerged. You try and take the person out of the
What if it's raining?
yeah, they said rain is fine.
Rain is fine, but that's not wet. The environment is wet.
Yeah.
It depends where you are. Okay, so
So then the stable mikve, basically.
Yeah, don't
Yeah.
do that.
yeah.
Yeah,
So it's more about the safety of delivering the electric shock rather than a reason not to. Okay, so first of all, you have to remove their clothing. Although the stickers are very good at sticking, they will stick to whatever you've put them on. And if they're stuck to clothes, then they're not stuck to the person. So you have to remove clothing. Okay. Hairy chests as well. They'll stick to the hair, not the chest.
Shall we? What should you do in that case?
There's razors with the defibrillator.
Really good razors.
Oh, you didn't see last week? Yeah,
Right, so
razor.
they're razors, but should I start just?
No, you take a razor.
Oh,
and
there's
you,
a razor.
It's
Like
a razor.
Yeah, it's really good.
Yeah.
You need to be able to get the.
No, that's not right.
It doesn't need to be a salon job. Okay. You just need the hairs to be really short. So the pads can stick onto the chest. Okay. If it's wet, they won't stick, so you need to dry it off.
Wet or sweat, basically. Wet or sweat.
Yes, any liquid. Yes, if it's that, yeah. So the other things we might need to consider if there's anything underneath it that could interrupt the delivery of the shock. So if the patient has a defibrillator implanted, so usually they're implanted under the left clavicle, so that if they need to be defibrillated, you can put the stickers on normally. But if they've, for whatever reason, if they've got a defibrillator implanted underneath the right clavicle, and you'll see it, because you'll see a box under the skin, don't stick the pad over it, because it will deliver energy into the wires, and number one, it will explode the battery inside the defibrillator, so the patient will literally explode, and secondly, that all that energy that's designed to go through skin, muscle, bone, and dead space is now going to go through a metal wire, and it will literally fry the heart because it's too much energy. Okay. The other thing is to think about if they've got piercings, so if they've got metal work, and some people do have chest metal work, so you either that or you take it out or you yeah. So you can't put it into metal work. Now you think they don't have to have implanted metal work, so they don't have to have piercings and nipple piercings and all that. A necklace. If you stick the pad over the necklace, the pad will shock the necklace, not.
If it would be nearby, would
So no, it needs to be touching.
touched?
Yeah.
So just that box you're talking about.
Yes. So defibrillator, that will be underneath the skin.
Yeah. So
How
it's,
do
it's
you-
not working for some
You
reason.
see it.
You see it. So we'll talk about the places that we can use instead.
But you definitely will see it.
You definitely see it. There'll be a scar about 5 centimeters in length, and a metal and a box that you see under the skin.
It's like pushing through.
Yes.
that-
It sits literally under the
Is
skin.
that pacemaker? That's it.
Pacemaker, yes. Yes. So a pacemaker or defibrillator, implanted defibrillator, it's the same. It's the same thing.
Would they not automatically defibrillate those? Because they not
It's failed clearly.
Oh, wait, that's not saying. No, is that a function of it that you can actually
Yes,
stop? Right,
yes.
that's what I thought.
Yeah. Or the other thing is patients who have chemotherapy or they have long-term intravenous treatments and have things called PICC lines or Hickman lines. So that's a catheter that's implanted under the skin. Again, you'll see a round button under the skin. Don't put it over that because again it will direct the electric current down that tubing rather than where it needs to go. So yeah.
I see it now. Yeah. You literally can see.
Yeah. So, if they're wearing clothes, you need to take their clothes off. You should not be doing chest compressions on someone's clothes. It should be hands to bare chest. If they're wet, dry them down. Towel, whatever. Their own. It doesn't need to be completely dry. It needs to be. It can be damp, but it needs to be dry so that the stickers stick onto it. Remove the hair. If they've got something that means you can't put a sticker in that place, so if you can't put the stickers in the normal position that they're designed on the stickers, so another option is to put it front to back, so you put it in the middle of the chest, so the one that goes underneath the right clavicle goes in the centre of the chest underneath where you're putting your hands, and the other one goes on the back opposite it. Yeah?
That's fine.
Over the spine, yes. So basically you're sandwiching the heart that way. Or if you can't do that, so they can go side to side. So you put the left one in the left armpit and you put the right one in the right armpit.
What's the voltage is delivered? What's the voltage is delivered?
300 depends on the machine, but anywhere between 150 and 360 joules of energy per shock.
Just
Joules, but is that volt? That's like
That's-
350 volts.
No, it's joules. So it's a different. So volts is a current, and this is joules. It's an amount of energy.
Just to clarify one thing, at the onset,
Yeah.
are you supposed to delay CPR to cut the clothes?
Yes, but you don't need. But it's cut the seams and rip. It's not.
Just really quickly.
Yeah. It's not. Don't cut around the designer labels and save it. It's Superman style. Okay. So just to summarise all that, so remember we're always going to check for danger first. We're then going to get a response, see if the patient responds to us, and do we need any additional help. So if the patient doesn't respond to us, we by definition need more help, so we'll call 999, call Azzolo, etc. And at the same, it doesn't mean we need to go, but if we send someone, good tip is go and call 999, tell them we've got an unresponsive patient or cardiac arrest, and then come back with a defibrillator to me. So you know that they've gone and called them and not gone and hidden somewhere and forgotten about it, and you get the defibrillator back to you.
Where will they find the defibrillator?
999 will tell them where the nearest one is available. Okay? Which is why, and that will tell you that they've spoken to 999 because they will come back with a defibrillator. We're going to do our airway manoeuvres, so we're going to look in the airway, we're going to do the head tilt chin lift, then we're going to check for normal breathing. If they're breathing normally, put them in the recovery position and continue assessing them. If they're not breathing normally, they are in cardiac arrest, so we will start doing chest compressions. So 30 chest compressions, 2 ventilation breaths, and we'll keep going. Once the defibrillator is available, we'll continue doing chest compressions while we tell the person who brings the defibrillator to stick the pads on the patient's chest around our chest compressions, and then we'll get the machine. Once it's switched on, we'll get the machine to analyse, see if we need to defibrillate or not, and then we'll continue. Does that all make sense?
So you don't stop doing CPR.
You stop doing CPR when the machine is analysing. Apart from that, you should be doing CPR.
Right. So you get someone else to do the stickers and.
Yes, and it's not difficult because if you're doing chest compressions, so one sticker goes up here and you're doing chest compressions here.
What if you're by yourself?
If you're by yourself, you go and call for help, because if you're doing chest compressions by yourself, every minute delay is a 10% reduction in chance of the patient recovering.
Every minute delay of what?
Of defibrillation and getting additional help. So if you're completely by yourself, you go and get the defibrillator and call for help.
Like let's say you've got a defibrillator, you come into the scene with a defibrillator in your hand.
So put the defibrillator on first, if you're by yourself.
Yeah, so you see that he's in cardiac arrest, put the defibrillator and start CPR.
Yeah. And while it's switching. Good morning, Shah. Okay. So it's that balance between we want to minimise the time off the chest compressions to keep the circulation going. But also, I know. And delivering that early shock, because the earlier we deliver the shock, the better, the more effective it will be. Okay. We spoke about it, so remove jewellery, make sure you're not putting it on a pacemaker or a defibrillator. Sometimes patients might have medication patches. Again, don't put the pad over it, especially if it's a GTM patch, because it might explode. If you don't notice it and it explodes, well, too bad. But if you see it, just don't use one of the other positions that we've spoken about. You've already mentioned don't use it in an environment where you might cause an explosion. And the last thing, make sure that you're not vibrating the machine, because the machine is very sensitive and it will pick up vibrations on the wires. So when you go out on calls and you have someone attached to the monitor on the ambulance and they're sitting there talking to you, and you switch the ambulance engine on, the machine will pick up the vibrations from the engine and will think the patient has a VF. Okay? So just be mindful of that. If you're vibrating the machine or the wires or the patient, it will not be able to analyse it properly. Okay? For the AEDs, the batteries have a date on them. In that way we will remind you of the date so that you can change the battery. There's also a thing on our defibrillators that shows you how full the battery is. Each battery is rated for about 400 shocks. So it is very unlikely that you will ever run out of charge on the battery. Okay? No, thank you. But just be aware that you need to check it, because obviously a dead battery won't deliver a shock, but you'll have plenty of warning before that. Okay. A general rule is try and replace the battery once it's been used, or by the date. Okay. And the stickers as well. They have a date on them. the date is actually quite important. It's not that they won't deliver a shock, but they have a gel on them to improve that connection, and also the stickiness will wear off. Okay. Coming back to the hairy chest, don't throw away your out-of-date stickers, because you can use them to wax the chest quite nicely. So you put an out-of-date stick on, it will stick to the hairs, rip it off, it will take the hairs with it, and then you can put an in-date stick on. And it saves you having to shave the chest. But remember that the stickers are out of date, so don't use that.
And you may wake up.
Is that a little bit dangerous to be
What?
having out those stickers and then
No, because
yourself
you
when
keep them separate,
Okay.
but
you write on them?
yes,
Out of
writing
date.
them out of date, keep them separate, so you have them as an age rather than having to you can shave. It's not an issue, but it's just a quick way of doing it. Okay.